Good morning, everyone. We're going to get started. Thank you all for coming out this morning. Just as a point of housekeeping, at the end of each row, there's a sign-in sheet. Dr. Mazzarelli is going to be requiring education on Ebola preparedness for all of the Cooper physicians, so you'll get credit for this session toward that. It's a pleasure for me to introduce our two speakers this morning. Dr. Henry Freymow is an associate professor of medicine and a member of the Division of Infectious Diseases. He completed his residency in medicine at Mount Sinai, followed by his infectious diseases fellowship at Einstein Montefiore in the Bronx, and he has had a very long and distinguished career in the practice of infectious diseases. He has several research interests, including bacterial pathogenesis and mechanisms of resistance, HIV infection, and tuberculosis. He is the hospital epidemiologist at Cooper. Our second speaker is Dr. Rick Hong. Dr. Rick Hong is a graduate of the University of Pennsylvania, both undergraduate and medical school. He also received a degree from Wharton. He's board certified in both emergency medicine and emergency medical services, and he's the division head of EMS, disaster and transport medicine for Cooper. He has many responsibilities in this realm. He's also he's involved heavily in the State Medical Coordination Center program, and he'll be offering an ACGME accredited fellowship in EMS beginning in July of 15. He's president-elect for the National Disaster Life Support Education Consortium, and he also serves as the medical director of the Office of Preparedness in Delaware's Division of Public Health. So shortly after the first two speakers, we're going to have two panelists who will be joining them, and I will introduce our panelists, Dr. Mazzarelli and Stephanie Connors, at that time. Henry, please come up.
Good morning. Can you all hear me? Okay. So I get to do the panic part this morning. Rick has the harder job of doing the preparedness part. And in order to prevent panic, there are two things that you want to do. You want to be educated and you want to act responsibly. Now, I can't help you act responsibly, but hopefully I will educate you this morning about Ebola, and just to put things in some context. I want to give two short disclaimers here. First of all, I have never treated a patient with Ebola or even seen a patient with Ebola. And in fact, there are very few physicians in the United States at this point in time who have, unless they've traveled to West Africa. So the cumulative experience in the United States is relatively small. I'll show you some of the people who actually have that experience a little bit later on. The other thing that I apologize for is that by necessity this lecture is US focused, okay? But the reality is that the Ebola epidemic in the United States is a very small portion of the Ebola epidemic, and the solutions to the Ebola epidemic lie in West Africa and not in the United States. So again, if there's a message, whatever we talk about here, it's trivial compared to what's going on in West Africa. Okay, let's see if I can get, okay, here's my next slide. And this slide is just a reminder that Ebola is just one of many emerging and re-emerging viruses around the globe that we have to be worried about. I've circled on this slide the Middle Eastern Respiratory Syndrome, or MERS, and it's important to realize there have been as many patients with MERS who have walked into an emergency room in the United States at this time and been diagnosed with that, as have walked into an emergency room and been diagnosed with Ebola, 2 of each. So, yep, you don't hear any talk about MERS, which is still going on in the Middle East. So then that brings up the point that when we deal with disasters and emergencies, we really have to adopt an all-hazards approach. And we can't be Ebola specific. We really have to generalize what we do and our responses to a lot of things, and Dr. Hong will be discussing that in much more detail later on. Okay, these are my learning objectives for this morning. You don't have to read this slide, but I've actually structured this as a series of questions. These are all questions that I have been asked multiple times over the last couple of months in some form or other, and I think that they're all the things that most people want to know about Ebola and our response to Ebola. All right, so here's our first question. What is Ebola and why is it so scary? All right, the next couple of slides are going to briefly summarize what we know about Ebola. I'm not going to read through all these slides in detail. I'm sure all of you who watch the news and go to the Times and go to CNN probably know as much about Ebola as I do at this point. But just a couple of points. Ebola is obviously a rare and deadly disease. There is a family of viruses that cause this. The Ebola virus itself is just one of the members of this family. We've known about these viruses since 1976, first discovered in Central Africa in Zaire, which is now the Democratic Republic of the Congo, and there have been periodic epidemics, mostly in Central Africa since 1976, and the natural reservoir we now believe are probably fruit bats. The disease that it causes is a viral hemorrhagic fever, which is a syndrome caused by a number of different viruses. The pathogenesis of Ebola is that it affects multiple cell lines, including endothelial cells, liver cells, and many other cell lines. It replicates, causes cell necrosis, and you get severe multi-organ dysfunction. You get tremendous amounts of cytokine release. And the pathophysiology that most people become sick and die from is severe fluid and electrolyte imbalance, followed by, in fatal cases, irreversible shock. It is sometimes, but not always, accompanied by hemorrhage. Even though we call it a hemorrhagic fever virus, really you only see the hemorrhage in about 20% of cases. The symptoms occur anywhere from 2 to 21 days following exposure. However, if you look at most of the epidemiology, almost all patients really present in that 9 to 11 day window. All right, so we have that 21 days as our outside marker, but most people get sick much sooner than that. The initial symptoms, which are listed here, are very nonspecific, and they can mimic that of other infections that people who are coming from an Ebola endemic area might have, like malaria. And as we enter into flu season, they can look like they have the flu. And that's the problem. The initial symptoms can be very, very nonspecific. Typically, the most common early symptom is fever, often high fever. This is what the physician in New York had. He was relatively well, except for a little fatigue, until he developed a fever to 103. The vomiting and diarrhea are usually later manifestations, often 3 to 4 days into the course or later, and hemorrhagic manifestations are only in about 20%. Some people seem to recover by the end of the first week, and they seem to trajectorize to getting better, and this is probably due to some level of innate immunity. However, other folks who get sicker, the illness generally peaks in that 1 to 2 week window, and that's when people become maximally ill. If you're going to get better, this generally correlates with clearance of virus and development of antibody response. However, even people who have cleared virus from the blood may potentially have virus still in other reservoirs. We don't know the significance of that and whether or not that's infectious virus, but there are studies that show that virus might persist in urine specimens and semen and other specimens for weeks after somebody recovers and clears their viremia. Those people who present with shock, with delirium and coma or hypoxia and higher grade viremia all correlate with a poorer prognosis. All right, so our second question. So what's so different about the current outbreak of Ebola from all of the previous outbreaks of Ebola? This slide is actually, I think this was from The Economist, but I thought it was a good graphic, and you'll see a lot of the figures that I show really have been taken right out of the news media. Ebola epidemics have been going on since 1976, but look at the size of this one compared to the cumulative total of all of the ones before. So this epidemic dwarfs all of the others by orders of magnitude, and this is also, most of the other epidemics have been confined to Central Africa, and this epidemic is isolated in West Africa. So what do we know about the current epidemic? Well, it started probably, we think the first case was back in 2013 in December. They believe that this was a small child who got infected, probably from some animal or environmental contact. We don't really know. But once this child became infected, the initial infection occurred in an area of Guinea called, I think it's Gekedu. I think that's the correct pronunciation. I don't know if anyone wants to correct me. I'm not absolutely sure. But that area is an area that borders on Liberia and Sierra Leone. And so what happened was the epidemic rapidly spread into 3 different countries. The mortality rate of this epidemic is about 70% in Africa, very different in the West, and we'll talk about that. And as of about 2 weeks ago, 13,000 cases, 5,000 deaths, and that number is rising. The worst case models, and again, models have been somewhat accurate up till now, but they're only models, say that if things don't get under control in West Africa, we're talking about an epidemic that may be anywhere between 500,000 and 1.3 million cases. The epidemic spread to Senegal and Nigeria, although contained in both of those countries, and there's been 1 case in Mali, no secondary cases so far. The most recent data looks like maybe things are a little bit better in Liberia, but maybe not in Sierra Leone. They may be actually worse than we thought they were. So why is this epidemic so different? Well, it's not the virus. The virus strain is the same. The infection is the same. The risks for transmission, the incubation period, the clinical manifestations are no different than all the other epidemics. But what is different about this epidemic is, first, it got into multiple neighboring countries. And these are 3 of the poorest, worst governed countries in the world, with long histories of civil war and chaos and relatively and very poor infrastructure. And the fact that it was in multiple countries was a big problem. It quickly got into crowded urban areas. The other epidemics were generally in rural areas far from large population centers. But the other features are the toll on healthcare workers, which I'll show you is not really a new trend with this particular epidemic compared to the other ones. But the other thing that obviously caught everybody's attention is the spread and now the transmission out of Africa. All right, and I don't see too many of the 2nd and 3rd year students in the room, but they've all seen me show this slide before, although this is a different airline than I usually show. This is the vector that infectious disease folks fear the most, the airplane, because that's the way that infectious diseases travel rapidly from one part of the world to another. This is a density map showing airplane routes connecting different cities. The brighter the band, the more airplane travel there is between different areas. The one good thing about this epidemic is there's actually very little airplane travel from this particular part of the world. It's hard to get out of these countries. There are only a couple of airlines, Brussels Airlines being one of them, that fly out of Liberia. However, cases have been brought out, and up till now there have been 19 cases out of Africa in the West. The first ones we actually brought out to give them care in the West, but there have been cases now diagnosed in travelers, and there have also been secondary transmission cases. So what this is an epidemic of firsts. A lot of first time we've seen this with this particular epidemic. We brought the first Americans out of Africa to be cared for in the United States back in August. We had our first travel-associated case in Texas, and I'm sure you all know this gentleman's name. He was diagnosed in 9/30 after he was presented to the hospital and sent home inappropriately, and then came back much, much sicker and subsequently died. We had the first healthcare worker-associated case in Spain, followed by 2 healthcare-associated cases in the United States who were caring for the gentleman from Texas. And now we have our second U.S. travel-associated case who was declared cured and released from the hospital yesterday. All right, so how do you diagnose and treat Ebola virus? All right, what this slide shows you is this is actually the model of the floor plan of the biocontainment facility at Emory, which is a state-of-the-art U.S. facility for treating Ebola. This is an Ebola treatment unit in Liberia. Obviously very different, principles are the same, but some of the things that can be done are different. First, how do you diagnose it? The test that's currently used to diagnose these is a real-time RT-PCR. Initially, it was only the CDC that was doing this. This has moved out to some of the state health labs. But what's important to understand is we don't make the decision for testing. That decision is made in collaboration with the health department. They're the gatekeepers of the test. So somebody can't walk in and say, I think I need to be tested for Ebola. If they don't have the correct history and the right epidemiology, they're not going to get tested. All right, so how do you treat this? And obviously we talked about the fact that this is different in West Africa than in the United States and Europe. There are no FDA-approved treatments. There are no proven effective vaccines yet. And the treatment is aggressive supportive care. Hydration, electrolyte management, oxygenation, hemodynamic support if necessary. Which doesn't mean that there aren't things that we can do, and I'll show you those in a minute. What determines how well you're going to do with Ebola? Well, host factors are obviously important because some people have a more benign course than others. How quickly you get to care and how good that care is going to be the determinants of your outcome. The overall mortality is estimated at about 70% in West Africa now. However, if you get optimal care there and get to like a Doctors Without Borders Ebola treatment unit, the mortality is 60% or less, and that mortality is actually improving as people are actually showing up earlier to those treatment units. So we know that the mortality is less if you get good supportive care in West Africa. If you make it to the West, the mortality is even lower, and the people who have died all presented probably too late for care to have made much difference. All right, there's a lot of experimental therapeutics because the less we know how to treat something, the more things we tend to throw at it, okay? You've heard about most of these on the news, and most of the data on these comes from the news. The ones in red are actually things that have been given to patients in either the United States or Europe. You all heard about ZMapp, which is a combination of monoclonal chimeric antibodies. Its precursor was actually ZMapp, which makes up 2 of the 3 of the monoclonals that are in ZMapp. It's now being made actually in tobacco plants, interestingly enough. But the current world supply of this appears to be gone, okay? And this was given to the first patients who came out of Africa, and as well as some folks in Africa. A number of antivirals have been used. This has been given to at least 3 of the patients, including the physician in New York. This was given to one of the patients in Nebraska. Lamivudine, and the reason this is on the slide is that a physician in Liberia reports good outcomes just giving lamivudine, although in vitro it doesn't seem to work, but people are looking at this a little more carefully. There are host response modifiers, and this has been given to folks in Germany, which sort of reverses capillary leak syndrome. Vaccine development. This is the fastest I think we've ever seen a vaccine get into trials and get out into the real world. The phase 1 trials of the first of these vaccines, which is a combination product with GlaxoSmithKline, has already been completed. The phase 1 trials in volunteers here, and the vaccine trial in Mali in healthcare workers started a couple weeks ago, and they already know that there are antibody responses to the vaccine. Okay, let's move on. So the next question, okay? This question I have been asked, okay? That's why it's on the slide. Obviously, the transmission of Ebola is very important. This shows you, this is the most famous bowling alley in the world, Gutters in Williamsburg, where the physician in New York went bowling the evening before he developed his first symptoms. This shows you the media circus outside of Gutters while they're watching the hazmat team inside decontaminating the bowling alley, which you could argue was probably completely unnecessary. And again, this points to the fact that we rely on our public officials to help guide us and act as responsibly as we try and act during the course of an epidemic, okay? And I have to give kudos to the mayor of New York City, who actually has done an excellent job in trying to allay the fears of the folks in the city. Okay, this picture is here because you can see this guy in the front who's elbowed the mayor out of the way. I said that there were no Ebola experts in the United States, or very few. He actually happens to be one. This is Dr. Link, who is Dr. Feingold's husband, who was taking care of the physician up in New York City. So there are some Ebola experts. If you actually have questions about clinical care, ask her, not me, because she's 1 degree closer to it than I am. Okay, so how do you get the virus? Direct contact, okay, with blood and body fluids of a person who is either sick from or who has died of. Died of being very important in West Africa, where the bodies are a major source of transmission. The handling of bodies is an important cultural phenomenon there, probably has contributed significantly to spread. However, in a sick patient, all of their body fluids are infectious. Contaminated objects can become contaminated, like needles and medical equipment. Theoretically, you can get it from contact with infected animals, although probably initial cases in epidemics, this is important, but irrelevant later on in the course of an epidemic. You don't get it through the air, although I'm sure there are questions about this because of some of the confusing messages that have been sent out, and you don't get it through food or waterborne transmission. All right, the virus only survives for a couple of hours on surfaces once it dries out, although in wet blood or body fluids it can linger longer, and you can kill it with common topical disinfectants, with bleach, with peroxide wipes. You can kill it with hand washing or using alcohol hand gels with greater than 60% alcohol content. This is not an indestructible virus that lingers forever in the environment waiting to leap on you unsuspectingly. Okay? So again, those who have no symptoms do not transmit virus. No matter what the public fury about this is, if you're not sick, you don't spread virus. So return travelers are not infectious if they have no symptoms. Returned healthcare workers who come from Africa who have no symptoms are not infectious. Even the first couple of days of your illness, you are only minimally infectious. The guy in Texas, when he first showed up to the emergency room and was sent out, nobody in that emergency room where they just used standard precautions, nobody in his household got sick. It was only when he came back later much iller and was hospitalized and we did all kinds of invasive things to him that healthcare workers were put at risk. Because as you get sicker, you get highly infectious. You can reach viral loads of up to 10 to the 8th to 10 to the 9th copies of RNA per ml, which gives you very high risk of transmission from blood and body fluids. All right, and now this slide is here because when we admit patients with suspected Ebola seen out in the field or in emergency departments, and highest level is probably way overkill for what you need to do. And our concern is that there are people who are going to die because we're too afraid to take care of them while putting on our maximal precautions for people who really have minimal risk of transmitting virus. And this is from the standards that have been proposed for first responders in terms of risk stratification for personal protective equipment. And you can see if you're asymptomatic or even early symptomatic, the level of protection that you really need is fairly low. Which doesn't mean that as you escalate and people get sicker, we don't escalate to higher levels of care. Next question is, why do so many healthcare workers get infected with Ebola, and what can we do about it? And obviously that's a big focus of what we do. This shows you, this is from the New York Times, shows you the number of healthcare workers who were infected in Africa, a large number, okay? No surprise, this is true of every Ebola epidemic. The people who are initially caring for the first cases often get sick and die, often are using not optimal personal protective equipment and care practices. However, this is the data from the Doctors Without Borders teams that have gone to West Africa. You can see from their teams, which use very, very strict adherence to rigorous personal protective equipment use and rigorous protocols for control of the care of these patients, the numbers are much smaller. I wish we could say they're zero, but they're not, but they're pretty low. And this is just a reminder, if you have a single patient with Ebola, like in a US hospital, the hot zone is around that patient. That is the area that is highly infectious. And as you walk out of that hot zone and appropriately take off your protective equipment, you move into a safe area. And the rest of the hospital, everywhere around there, is pretty safe. In the midst, this is the design of an Ebola treatment unit. This one is from the Firestone Plantation in Liberia. And the setup is pretty much the same. Maximal protection here, suspected patients here, they're not commingled. Same precautions that we use here. The difference is, in Africa, the green zone isn't so green. When you're in the midst of an epidemic, there's a lot more virus outside of this facility that you don't know about. And if we just go back 1 second to this slide, in this outbreak here in healthcare workers in Liberia, it wasn't the ones in the Ebola treatment unit who got sick, it was the ones in the hospital next door who didn't think they were taking care of Ebola patients, but probably were the ones who got sick. Okay, so what's so complicated about treating patients with Ebola virus disease? And not to be cavalier, nothing and everything, okay? The medical care is the same. We all know how to take care of sick patients with septic shock, volume depletion, fluid and electrolyte imbalances. What's different is how we look at these patients and how we have to think about taking care of them. We have to take care of ourselves at the same time as we take care of them. It's more akin to dealing with toxic radiation or toxic chemicals or firefighters going into a burning building. You have to think about what you do before you do it and recognize the risk to yourself. You also have to think about the risk of everything you do in the care of this patient. Every blood sample that you get that has to go to a lab to be tested exposes people downstream from that. So you really have to think about every intervention you do, and is there risk and is there benefit, and does the benefit outweigh that risk? The processes of care to minimize risk are incredibly cumbersome and complicated. They certainly increase safety, but there is a cost to this, and I'm not talking about financial cost. The cost of wearing all of that personal protective equipment, it's hard to put it on. You can't work very long in it. It's uncomfortable. So there are a lot of consequences to what we do. The logistics are really complicated. If you think about it, the patient in New York at the peak of his illness was generating 30 55-gallon drums of red bag waste a day that needed to get out of the hospital safely to an incinerator. How do you do that, right? Think about the logistics of just managing that kind of a waste stream. All right, and if we have time, we'll show you a brief video about the personal protective equipment that's currently used. So this is obviously the questions that we all as epidemiologists want to know. Will we have spread of Ebola in the United States and have an epidemic? But the real question is, will Ebola be contained in Africa? And I'm showing you, this isn't the United States, this is Nigeria, okay? Nigeria had a single patient, 3 generations of transmission. But with mobilization of their emergency management team, which Dr. Hong will talk about the structure of emergency management, and lots of good public health, almost 900 contacts of these individuals were all followed, and the epidemic was extinguished, okay? So if it can be done in Nigeria, it should easily be able to be done here. Will there be more Ebola cases in the United States? I would say absolutely, until the West African epidemic is contained. Will there be clusters of cases? Possibly, depending on how well we contain and prevent transmission from those cases. Will there be sustained transmission in the United States? Highly unlikely, okay? So I'm just going to talk about the role of Tier 1 and Tier 2 hospitals and where Cooper fits in all of this. The Tier 1 hospitals are the designated biocontainment units like Emory, Nebraska, the NIH, and most people would say Bellevue rises to that level because they have expertise in caring for sick Ebola patients. All right, Tier 2 patients are the ones that the states have designated and the CDC have vetted, are the hospitals that can see patients and at least initially manage these patients, although not necessarily handle the sickest ones. In New Jersey, these are all clustered around the airport because that's where people are likely to come in. However, there is a role for all hospitals to be prepared to see and assess those with suspected Ebola virus disease. So what might happen at Cooper over the next 12 to 18 months? We will certainly see people who have travel exposure history. We will likely see patients who have exposure history and might have some symptoms that you might think about Ebola virus. We are not likely to see, but could see somebody with Ebola virus, and we have to be prepared. And it is highly unlikely that we would see somebody with suspected or confirmed Ebola virus. However, we have to be prepared, and we might see somebody who is seriously ill, although it is unlikely that people are going to show up that sick with their first diagnosis. Screening protocols are really critical to identifying these folks early. We've talked about risk factors, which is either from travel to an infected area or a household contact of a sick traveler or a known Ebola virus case. But almost anything else, and we've seen a lot of false alarms, doesn't meet the criteria of a true exposure history. This is the screening protocol in place at Cooper that is pretty much set up at all portals of entry to the hospital. So who's going to take care of these patients? And I think this is my last slide. Who's not going to take care of them? Medical students and house officers will not be taking care of these patients. And I can tell you some of our fellows are actually unhappy about that because they think that it should be part of their training experience. Anyone who is not appropriately trained to use personal protective equipment is not going to care for them. And nobody who's not absolutely necessary for their care is going to take care of them because you don't want people going in and out of these patient rooms who don't really need to. So the concept is that volunteer teams who have received mastery level training in the use of Ebola-specific personal protective equipment and using very specific protocols designed to minimize risk are the ones who are going to care for these patients. And it's important to realize that we're not all equally important in this process. It is far more important to have trained critical care nurses to care for these patients than a trained infectious disease doctor like me who probably brings nothing to the process. I will certainly be one of these people who's trained, but let's face it, you'd probably rather have a critical care nurse taking care of you than me in the room probably not doing a whole lot useful. Okay, and so I'm going to introduce Dr. Hong, who's going to take over here.
Do you want this? Yeah, I guess. Okay. Thank you. Tough to beat there, Henry. I'll tell you that right now. I'll do my best. So I have the pleasure of talking to you about what Cooper's actually doing in terms of Ebola preparedness and response. So kind of want to step back and talk about overall emergency management planning. And we have to start off with the definition. What exactly is a disaster? Working in the emergency department, we can say it's a disaster every day. But there is some criteria per se when exactly a disaster is occurring. And most people would probably agree that this appears to be a disaster. So we have a couple of definitions of disaster. You can see a common theme to pretty much all of these definitions. There's a serious disruption of the function of society, causing widespread human, material, or environmental losses. You have a definition from FEMA, natural catastrophe, technological accident, or human-caused event, resulting in severe property damage, deaths, and/or multiple injuries. This is a definition from National Disaster Life Support, again, talking about serious disruption to the normal functioning of a community, causing widespread human, material, economic, or environmental losses, and that exceeds the capacity of the affected area to respond without external assistance. So kind of sum it up, what exactly definition of disaster is basically your needs outweigh your resources, you can't manage the event, hence that equals to a disaster. So using that basic definition of disaster, is Ebola really considered a disaster? How many confirmed cases of Ebola do we have right now? 0. Yet a lot of resources are being put into it. So the question is that the right thing to do? How about zombie apocalypse? I don't know if you guys have seen this before, okay? I'm not a zombie fanatic per se, but the CDC used this propaganda to kind of increase awareness for preparedness. So back in 2011, this campaign came out through the CDC. Initially was kind of a joke, and it referred to Walking Dead. And I don't know how many of you guys are fans of Walking Dead. You don't have to proclaim that, okay? You don't have to, But there are a lot of folks out there that are fans of Walking Dead, and apparently one of the episodes in the first season, the group of survivors running away from the zombie apocalypse actually infiltrated the CDC headquarters and found out the CDC was not prepared to handle a zombie apocalypse. So CDC took advantage of that and started using this campaign, which became very successful and got people more aware of preparedness in general. So would a zombie apocalypse be considered a disaster? I'll defer that one later. So focusing on Cooper, did Cooper have an Ebola plan prior to this epidemic in West Africa? The answer is Cooper did not have an Ebola-specific plan prior to this event. Should Cooper have invested time in developing an Ebola-specific plan? So, we do have resources, we do have personnel to kind of do the planning process. Should we had enough foresight to say, something, maybe Ebola would have happened sometime down the road, maybe Cooper should have been prepared and write up an Ebola plan. How many of you guys remember that earthquake we had a couple years back? Yeah, I remember in the emergency department just sitting at the doctor's bubble, and all of a sudden I see like one of the cabinets kind of shift over, and I'm like, wow, that really should not have happened. So we really did not have an earthquake plan, but does that mean that we are unprepared? The answer is no. So the question is right now, and I get this question a lot, is Cooper prepared for this event? And I would argue to say that Cooper was prepared for the event prior to the epidemic because we used something called an all hazards approach. When you're working with emergency management, it is utterly impossible to have a plan specific for every disaster that could happen. So you need a disaster plan for weather emergencies. We need a disaster plan for active shooters. We need a disaster plan for staff shortages. We need a disaster plan for infrastructure disruption. That is utterly impossible to create all those plans. So we use an all hazards approach, and basically what that says is that there are many common features in emergencies that use same management strategies. So let's just build a foundation for overall planning, and then from there we kind of build based on a specific incident. And that's the approach we use, as well as many other institutions out there. We currently have a lot of partnerships among all levels of government. Henry and I have been very busy. We've been contacted everywhere from the local level to the state level, actually also the federal level, to help deal with this event. We also have been dealing with private sectors. Actually, I just met with the aquarium 2 days ago to talk about what would happen if the aquarium had a suspected case of Ebola. So we need to work together with all our partners to kind of make sure this does not spread. In all emergency management planning processes, there's a life cycle. So we have to make sure that we go through those series of management phases. We have to establish strategies to mitigate hazards, prepare for and respond to emergencies, and recover from events. This is the same approach we use no matter what could possibly happen at Cooper. This is just a picture of the life cycle of the 4 phases, starting from mitigation to preparedness to response and recovery. And again, we are using this approach to address this situation. To define the 4 phases, the first step typically starts off with mitigation, which is to prevent future emergencies or to minimize their effects. Next, we talk about preparedness, which is to prepare to handle an emergency. Then we talk about the actual response, responding safely to an emergency. And then finally, recovering from the emergency so we can do this all over again. So we are constantly busy, so to speak. We have something called an incident management team, and I think this event has shown the importance of having a structure such as this. We do have an incident management team. Henry and I are part of that team for this specific event. This is represented by selected core members of the Emergency Management Committee, and I'll talk more about that committee. And we are responsible for consultation, information tracking, initial response to an event of significance. We can expand based on the event. So because this is an infectious disease event, we have included ID as well as infection prevention and control into our team. We are available 24/7. So if there's any incident that you're concerned about, you can contact us. This is our email address up there, so feel free to email us. We also do have a phone extension, which is 968-7900, and basically you call if there's a situation or you hear about a situation that might be happening and you just want to let us know what's going on. Like I said, we do have a team that's available 24/7 at all times. So I mentioned something about, I mentioned the Emergency Management Committee. So we have a team of experts in these 15 functions so that when any disaster occurs, we make sure we have someone who knows what they're doing addressing each of these support functions. This mirrors the national level, so there is definitely some standardization in terms of how to approach a disaster. So we do have departments and divisions assigned to each of these support functions. And again, this core group composes the Emergency Management Committee. This is something we live by in terms of structure. You can imagine during a disaster situation, it's very chaotic. You know, people are a little panicky at times. We want to make sure there's some structure when we respond to a disaster. That's very important. So any situation that we're dealing with, whether it's something routinely occurring at Cooper or something that's not routine, we follow this incident command system. So we have someone in charge or a group of people in charge. Does that mean that those folks are the ones that are most knowledgeable? Not necessarily, but someone who is able to communicate with everyone, someone who's able to gather all resources and basically improve efficiency during your response. There are 4 main functions in any disaster. You need people who are the thinkers. You need people who are the doers. You need people who are the getters and people who are the payers. And again, in this situation as well with Ebola, we do have teams specifically assigned to each of these functions in order to manage this event. So talking specifically about Ebola, so I'm going to go through the 4 phases of emergency management. So talking about mitigation, how can we avoid this event? Well, I'm not sure we can avoid this event, so we're going to focus on how do we reduce the risk of getting Ebola transmitted to our staff. So we need to make sure that people are aware of what's going on. So, we are involved in meetings every day. There are emails going out. There's information on the portals to keep you up to speed of what's going on. We want you to know what's going on in terms of spread of disease, where the disease is at this time. The exposure risk, I think, is very important. To prevent or reduce your risk of exposure, you need to know how to get into the first place. And also, we work closely with the federal and state governments, as well as public health departments, et cetera, to really make sure that we kind of fall into line with what they're doing. So, for instance, Henry mentioned before with the airports, our 3 tier 2 hospitals in New Jersey are located around Newark Airport because that's where our highest risk is going to be. Governor Christie has a quarantine policy in place. There's a screening process as well to Newark Airport. We want to make sure that what we're doing goes along the lines of what they're doing. Education is key. We want to make sure that we as healthcare providers are the leaders in this because people are going to be asking us, how do we protect ourselves from Ebola? We have to make sure we're on the same page. So we need to understand exactly how to transmit the disease and how to protect ourselves. So that education has gone on. It will continue on further to make sure that we're on the same page on this. Moving on to preparedness, we have an incident command system in place specifically for Ebola. Again, we have our experts, subject matter experts involved. We have those disciplines involved to make sure that we are in control of this situation. We have created standard operating procedure specific for Ebola. All these things have come up during our tour, so to speak. So screening process, Henry mentioned before, one of the things we want to make sure is that we have a screening process in place for all portals of entries. So we're talking about ED, we're talking about the transfer center, we are talking about offices. All these folks need to make sure that they have a screening process in place so that we do not bring someone into our institution unaware that what the risks are involved. Personal protective equipment is something that's a hot topic right now. It's very difficult to buy a mask nowadays, you can imagine from your vendors. But we also have to remind folks that, what you see on TV, people in those astronaut suits, they're wearing those suits because of a certain risk level and whatever their job function is. Can you imagine one of us trying to go in and take care of a patient in an astronaut suit? Is that going to work for us? Well, if that's not going to work for us, then that's not the right PPE for us because we still have to do our job. We still have to take care of our patients. So we need the appropriate level of PPE that supports what we're doing out there. Also, you have to remember, more is not better. I've had a lot of questions come up to me. It's like, well, I want to wear everything. Well, if you look at those healthcare associated cases in Dallas, we suspect that the reason why they got sick was also due to the PPE, that they did not know how to use it appropriately. So you can imagine the more stuff you put on, the harder it is to take off, the more likely you're going to do it wrong and potentially self-contaminate yourself. So we kind of remind our providers more is not better. It complicates things even more, and especially if you're not trained to use it appropriately, you're actually more likely to get contaminated from use of the PPE. Patient care areas, we have pre-identified certain areas within the hospital to care for these folks, these suspected cases. In the ED, we have identified 2 rooms. In a hospital, we have identified 2 rooms as well, too, that really offers that appropriate level of isolation, which pretty much means 4 walls, a door, and a private bathroom, more or less, okay, to limit that spread of disease. Patient care transport is also very important. We want to make sure we're not moving these folks unnecessarily and also moving these folks and potentially spreading the disease. So we work closely with EMS. If EMS is bringing in a patient that's suspected of having Ebola, we're not letting them in the door. Our team would actually meet them outside and then isolate them appropriately and then bring them in safely. That also applies for patients coming from the emergency department up to the floors. We have to make sure we have a plan in place to transport them safely. And of course, I mentioned before the transfer center, we have to make sure that we do not have any suspected cases coming in that we're not aware of. So we're hitting all those points of entry. And the big question I have, and I'm personally passionate about, is the standard of care. What is the standard of care for patients with suspected or confirmed Ebola? Do we continue to do what we normally do, or do we have to consider the risk to the healthcare provider and whether that outweighs the benefit to the patient? So one question comes up is that unfortunate case in Texas, that patient went through dialysis. Was that appropriate? I don't have the answer to that. I don't know if Henry does, but you have to ask yourself, you're putting your providers at risk going to that extent. Is that really worth it? So we need to talk to our bioethics team to talk about standard of care. We've had a lot of discussion with subspecialties as well. What do you do with someone, if there's a mother with suspected case who's delivering? What do you do with the mother? What do you do with the baby once it's delivered? Talked about with surgeons. What do you do if someone has an emergent need for a surgery? How do you manage that patient? So all these questions are out there, and as Henry mentioned, we are not experts in Ebola, so we have to work together with all levels of health to find out what's the best thing to do for these patients. We are providing PPE training. There's going to be some education out there to give everyone some basic level of PPE. I can speak for myself as a healthcare provider. I am not good with PPE usage, okay, because I don't use it every day. Do I know what to do? Yeah, I think I can fumble around, but I don't want to fumble around with Ebola, correct? This is not the time to kind of test myself to see if I know what I'm doing. So we want to give people reminders on PPE training. So I want to take advantage of this opportunity to just kind of give us that education and just forget about Ebola, but just good, basic safety for providers. Communication is very important. We are working closely with public relations to kind of make sure the message is correct out there, not just internally, but externally as well. And then Henry mentioned something about volunteers. I can tell you from an emergency manager standpoint, if I had to train 6,500 employees at Cooper how to use PPE appropriately, that's not going to work. So let's just kind of go and ask for volunteers. Maybe we have folks out there that are already trained. We have a lot of talent here at Cooper. It's amazing what we have here at Cooper. We have folks who used to be in the hazmat team, people here who worked in EMS in the past, people who work in the military. These folks are more familiar with this process. So let's hit those people first. And I'll tell you, I am overwhelmed with the number of volunteers we received. I mean, the physicians, nurses, allied health. I mean, we got a lot of volunteers here that we have a really good team right now to manage this if we had to. If we actually had to respond, You know, the screening process is in place. We ask about travel history. We ask about exposure to sick contacts. We talked about symptoms. Then we kind of figure out whether this person is truly at risk for having Ebola or not. If this person does, we will isolate immediately. How do you isolate the person? Get them into a room. I don't care what the room is. You know, there's some recommendation it should be negative pressure. Yeah, if the patient crashes, but honestly, if you're in an ambulatory setting, you don't have negative pressure rooms. Get them into 4 walls and a door. Get them into a car. Get them somewhere where they are safe and isolated, and then you can take it to the next level. Provider safety, very important. Do you really need to be with that patient? Do you really need to touch the patient? How much of an exam do you need to do? You have to kind of keep in mind what are the risks and benefit, and the more you do, the more you're at risk. So we need to step back and say, you know something, I always order CBC and Chem 7 just because I can. Does that person really need a CBC and Chem 7 if they're walking, talking, normal vital signs? Do you really need to put an IV in them just because they're being hospitalized? Again, questions you need to kind of think about. So risk and benefits of intervention, very important. And finally, recovery. Look at what you've done. How can we do it better? Do we need more training in PPE? Do we need to look at our operating procedures? This is an opportunity to improve what we're doing and then move forward. Staff quarantine is something we mentioned before. If we do have a suspected case, what do we do with those healthcare providers? Do we have to quarantine them? What do we do about their pay? These things are very important. You know, what do we do with our volunteers? They're accepting a higher risk. What should we do to make sure that they're okay? Expenses. How much money have we put into this so far? You can imagine the additional supplies, the additional training time, staffing to educate, my time, Henry's time. You know, this is affecting what Cooper normally does. So how do we recuperate from the expenses we're putting into this? And then, of course, always, you have to prepare for the next disaster. You know, we're dealing with Ebola. There's weather around the corner. So right now, I'm having nightmares about Ebola. I'm having nightmares about hurricanes. I'm having nightmares about snowstorm. All this is right now in my mind. And of course, we're in flu season as well, too. All right, so my job is a little bit, has not ended yet. Just to show you a picture, this is our incident command system just for Ebola. And again, it's small, I don't care about the names, I just want to show you that we have a structure in place. You know, we do have an incident commander, so to speak. We have our experts here. We have someone who are the doers, as I mentioned before. So these folks are the ones who are going out there and doing the training, the ones out there doing the planning, the processes, procedures, and so forth. We have the logistics who are ordering the supplies, so we're getting our masks, we're getting our hoods, we're getting our booties as we need. We have our finance guy who's, you know, paying the bills, and then we have someone who's actually responsible for planning. What's our next step after this? So we do have a structure in place, and we're moving forward. So conclusion, we are using all hazards approach. So no, Cooper did not have an Ebola plan before this happened in West Africa. Did we need one? The answer is no, because we had the basic foundation for any disaster that could happen at Cooper. We just need to build on that. We went over the 4 phases of emergency management. Again, we're going through this like we would any other emergency. We did create some Ebola-specific initiatives, again, because we had to make sure that we are addressing those differences with the disaster right now. There were only 4 confirmed cases of Ebola in the United States, and as I mentioned before, how many confirmed cases now? 0. 1 death, everyone else cured. And I just want to have a general reminder, and this is what I do for public health, we're focusing all this attention on Ebola. You know, there's something called flu out there. It kills more people than Ebola in the United States. There are more people sick from it, yet so many resources are being put into Ebola. So let's just have a reality check here and make sure we don't forget our basics. And remember, flu's here, we need to focus on that as well. These are some links again for PPE. For those of you that are on our volunteer team, you're going to have hands-on training for the PPE, but I think that everyone needs to have some understanding of PPE because that's just part of our job as healthcare providers. Okay, thank you very much.
Well, we'd certainly like to thank Henry and Rick for setting a wonderful platform of information and putting things within context and perspective. We're running a little late on time. We started a few minutes late, but I would like to at this time invite Stephanie Connors and Anthony Mazzarelli to come up and join. For those who are able to stay and ask a few questions, Stephanie is our Senior Vice President for Hospital Operations and Chief Nursing Officer, and Anthony Mazzarelli is Senior Vice President and Chief Medical Officer. They both bring interesting perspective, I think, to the panel. So I'd like to, at this time, ask if there are any questions for any of our panelists. Yes.
This is a question for Henry. In the Tier 1 hospitals, the slide with the Tier 1 hospitals, did I see correctly that it was 10 in Nebraska and 5 in Montana?
Those are the number of beds, okay?
Yes.
So,
Because that's the
right,
argument.
so a total of 19 biocontainment beds in the United States, although there actually isn't staffing for 19 beds. One of the hospitals that has 10 beds really only staffs 3. It takes a lot of nurses. I mean, I think it took a minimum of 20 nurses working around the clock per day to take care of the patients at Bellevue. So it takes a lot of personnel to care for these folks. But it's unlikely that we would exhaust all 19.
Other questions? Yes.
In case of a disaster, let's say you do have a suspected case of Ebola, who can initiate like the response team, or in other words, like how can we initiate that?
So right now, there is a process in place that if there's a suspected case at one of the ports of entry with a positive screening, if you are off-site in an ambulatory office, they're supposed to call the IMT. And that's part of their protocol right now, and hopefully the ambulatory folks they've actually used it. Henry and I have received calls a couple times asking about, is this an Ebola case or not? So the process seems to be working. The IMT is there basically to facilitate the process. So if you're ever in doubt, just call the 7900 number or email, and then someone will get back to you and walk you through it. We just want to make this as easy as possible.
Ed?
So a patient walks into Salem Hospital. Should that patient come here? Should that patient go to Huck? Should that patient go to Emory? Why would we have all these different hospitals replicating the experience rather than send them to a separate place?
Right. I mean, that's a very good question. Right now, the non-tier hospitals are expected to manage any person coming through the doors. So at that point, Salem's expected to contain the person in the emergency department. If the screening process is correct, they're supposed to transfer patient actually to the Tier 2 hospital and to provide further care. So they should not be sending that person to Cooper and then Cooper sending them to a hospital up north. They have to go through the normal transfer process. So they have to get a receiving doc and all that stuff. Typically what happens is they need to go through public health for that and then work their way through. So there's really no reason for Cooper to take these patients if there's really a high suspicion for Ebola, because we'll just have to transfer them out anyway.
Yes. A Brig.
So are the answers based on high suspicion or are they based on clinical testing?
Right now they're doing on suspicion, but if the cases become greater, the number of cases, they may just be confirmed. So again, just based on the resources out there and the demand for services. Right. I mean, that's what they're doing in the airport right now. If they are coming in with symptoms with a positive exposure risk, they're going straight to one of those hospitals.
How long does it take to get a definitive answer back on the viral?
We're fortunate enough that the state lab here in New Jersey can do the test, so we've been told that maybe we're talking about at most 2 days.
And actually, in some instances, the test has been back within about 6 hours, depending on what day of the week, what time the patient comes in. They send actually a courier to collect the specimen and take it to the state lab to run. The problem is that very early on, the blood test can be negative the first day of symptoms because the viral load may be so low. And sometimes these patients have to be admitted and observed for a day or two. And that's kind of the gray area where you are likely to see patients who might get admitted in that, well, we don't really know what's going on. Do they rule in? Do they rule out? And that's what we're much more likely to see here than somebody who we know has Ebola, who is highly unlikely to say.
I have a question for Dr. Mazzarelli. Could you make some comments? I mean, you have a very interesting background, MD, JD, and Masters in Bioethics. Could you make some comments on quarantine laws?
Sure.
And recent activities in the state of New Jersey?
Yeah, I think that the case in New Jersey is sort of what Dr. Fremont just talked about. It's interesting because the woman that was quarantined had a fever, right? So she had some symptoms, but not all the symptoms, and that's where sort of was in that gray area. The ethics around this are twofold. There's the quarantine, and there's the misconception in the public, and I think that's what leads to issues with quarantine laws. What I've been saying to people a lot is that what's happening out there, and with respect to thinking about quarantines, is that Ebola is highly, highly infectious, meaning exposure to very little virus means you get Ebola, but not highly transmittable. That exposure needs to be substantial. It needs to be with fluids, and it needs to be of someone who's very sick. But the media conflates those two things together and doesn't talk about between the two. So what happens is that everybody wants anyone who's been near anyone quarantined. And the idea of we also haven't communicated well enough to people so that the fact that we want to do contact tracing to people who have been near someone who is asymptomatic, people feel like, well, that is the opposite of saying you can't get it if someone's asymptomatic. And so those mixed messages haven't had a leader who has stepped up and is the Rudy Giuliani post 9/11 leader that has really taken, that everyone trusts when they talk about Ebola. Therefore, quarantine seems like the best idea because, well, if we just don't let anyone in who's ever been to someone with an Ebola, it will be 100% effective. The problem is it comes at a cost, and those costs have to do with individual freedom and whether scientifically it really makes sense. And so that's where I think you run into foul of some of these things. You also may have the legal ability to quarantine with the police powers. That doesn't mean it's the right thing to do. When you have the right to do something, doesn't mean it's right. So I think that you will see what happened in New Jersey as most, I think, public health experts say probably was not the right thing to do. But you'll see it will be praised because of the misperception that the public has about what's going on. I mean, like Dr. Freeman talked about, you can't get Ebola from a bowling ball, but you can if the bowling ball has vomit from an Ebola patient on it, right? So someone would say, see, you're wrong, right? Yeah. So,
I was going to say you can't get it from the bowling ball, but what about the sweat in the bowling shoes?
Right.
So,
or,
that was only a joke.
That's what you have to think about. I always get asked, can you get a sexually transmitted infection from being on a toilet seat? And the answer is yes, if you're having unprotected sex on a toilet seat. So we need someone in the public health arena who can really educate people on what's happening. And the second thing is, just like Rick just said, the rules will change as the prevalence rises.
Yes.
And those changing rules get perceived as having gotten it wrong before. And that's a huge problem.
Thank you. Paul, your question.
For Stephanie and Maz. So as Henry mentioned, we're in flu season. So what's the protocol? Somebody shows up in an outpatient facility with the requisite symptoms, and who asks the question?
They are to put the patient in the room, they're to mask the patient, and they're to call IMT, and then we take it from there. So there's questions asked up front before they even register. As they're coming in the door, there's a protocol and a document that helps guide them on what they need to do, but it's very, very simple. Put them in the room, mask them, and make the call.
I have a question for Stephanie. It was our perception, actually, Paul, because his daughter is a nurse, and we saw some traffic with the nursing unions really getting behind this in a very proactive manner. So we saw a little bit of in 2009 with pandemic flu, but this time it was our perception that the nursing unions were all over this, pushing public health groups, pushing the CDC. Can you make some comments on this?
I can. I have to say, in anticipation that the unions would react to this global concern, of course, with the media and the raising of the anxieties throughout our country, we here at Cooper made an immediate phone call to the union and partnered with them on communication, not only out to our nursing staff, but so that they were well informed on what we were doing to protect our staff. It's interesting because Maz and I had a comment, and it is more in this situation that we're looking to protect the provider. Not that we're always protecting our patient, But in this situation, it was so important to make sure that our frontline staff felt as though they had the knowledge, the education, as well as the support, that if we were faced with an active case, that we were prepared to take care of that patient, but even more so prepared to take care of them. So I think we did a very, very good job in partnering. As it was communicated earlier, did we do this in advance of the first case? No. But as soon as the first case developed, we were all over it. And I feel fortunate because as I was watching all of the media around nurses striking, I can tell you it goes to my core, and I said this earlier, because we are here to take care of patients and to take that stand and take you away from those sick patients that are more prevalent now, flu and other disease that's out there, and to go out and strike based on a very significant what if was something that I did not want to be faced with at Cooper or in our market or really at all. So, I think that we're in a good situation because of that elevated communication.
Yeah, just to sort of add to that, so few patients have contracted Ebola in the United States that it is not a crisis, as we talked about. But the fact that you have even one healthcare worker that gets Ebola from taking care of an Ebola patient starts to think about a crisis of, are we prepared? So I think that's a fair response, and I think we responded accordingly. First, having the incident command structure and the work that Dr. Hong and Dr. Freeman have done sets us apart. And then you add that with running towards our staff with training and those kinds of things. I think that's how we can be prepared. But I think it's fair that healthcare workers in this country particularly the nurses, have raised their hand and said, hey, this is really a problem. Despite the fact so little people have gotten Ebola, it's a caregiver's disease. And so I think caregivers wanting to be properly trained is a fair thing.
Any other questions for our panelists? Any other comments from our panelists? Yes, Mike.
I just want to draw a bright line to Rick's statement earlier about all hazard preparedness. And the IMT has existed at this organization for a very long time. In 7900, as a phone number, has existed in this organization for a very long time. So I think the one take home from all this, because we're probably not ever going to see an Ebola patient, is now you know the number for the IMT. So anytime you have a logistics issue, a preparedness issue, you're worried about resources, 7900, there's somebody there 24 hours a day, 7 days a week, and that person's been there for years. Well, typical actually, but now you know the number, so next time the next unforeseen issue comes up, you know what to do and who to call. And that's really, I think, the biggest take-home point of this whole thing and Rick's work in general about preparedness in this organization. I want to thank you for making sure that it's working nicely.
You'll get my overtime bill very shortly.
Yeah, well, Paul.
I want to make just a quick comment. I want to thank all the panelists for speaking. It was very timely. And more than that, I think the way in which the hospital has gone about communicating with everybody, sending that information, I think is exemplary. And Maz and Stephanie were kind enough to connect all our students with the emails that were
Yes.
out. So a wonderful learning opportunity for them. Congratulations to everybody who was involved in this whole in a wonderful way. So thank you.
I'd like to add our thanks to Henry, Rick, Stephanie, and Maz, not only for coming this morning to do this, but also for the leadership that they've shown in preparedness. I think that that's been great. The rollout of this, as Paul said, has been fabulous. Thanks for including our students in the educational process. So thank you very much.